Hi everyone and welcome back to XGate Dental. I'm Emmanuel Kadosh and we are here to discuss new procedures in the field of dentistry. We will provide interesting new cases to exhibit how doctors use our products to solve complicated dental cases. So don't forget to subscribe and follow to stay up to date. So let's get started. Today we brought a case of restoration on implants using multi-units. Now the interesting part about this case is that at first we had the osseointegration period of the fresh implants, and in that part we performed a temporary restoration that was fixed on tooth 23 for aesthetic reasons. When we have full osseointegration, we extract the tooth and then place an implant instead, and then on those 3 implants in this case, we make the final restoration. So here you can see the temporary restoration, which is a small Richmond bridge fixed on tooth 23 with 2 cantilevers. It's a little problematic to use this kind of structure as a permanent solution, but as a temporary restoration, we took it out of occlusion and we used the Richmond bridge during the recovery period of the first 2 implants that we placed. Now, even though it's not in occlusion, it's problematic because when you eat, the food applies force on the cantilever area, meaning that the tooth itself can break. Therefore, it can serve as a temporary solution for 2 to 3 months, and that's pretty much it. Without it, it will be a major aesthetic issue because the implants are in the posterior area and cannot be loaded at this point. Because a lot of force will be applied on these implants that can interfere with the osseointegration process, here you can see after the osseointegration was completed. We opened a flap, fixed the V-type multi-units, and we took impressions on multi-unit level using scan abutments. There is the canine that we restored temporarily, which we used as a base for the Richmond crowns. Now, later we'll extract the tooth and we'll place another implant instead of it. We are planning a 4-unit restoration. 2 of them are molars. We do want at least 3 implants. Here you can see the healing caps. Now, the interesting part is, even with the healing caps, we still could mount the old Richmond bridge on the canine. So for these few weeks of healing, she'll have some sort of aesthetic solution. Now, we do want it for aesthetic reasons because it's a little problematic when you have only the incisors and from the canine and backward, you don't have any teeth at all. After some healing, we took off the sutures. We can see here 2 of the multi-units and we extracted the canine and immediately placed another implant. So in the meanwhile, instead of the Richmond bridge, we'll have a PMMA bridge on both implants with V-type multi-units and a cantilever instead of the canine. This way we have 5-unit bridge, right? 2 molars, 2 premolars, and a canine. Now the canine is the cantilever, and below the canine there's an implant that we want to wait for the osseointegration to be completed. Now, we're adding another implant to get more support on this canine, and in this case, for 5 teeth restoration fixed on 3 implants, it's fine. Now, while we are working on the upper jaw, we have another small restoration on the lower jaw where we have 3 implants, and on those implants, we have multi-units. You can see here that we have 3 V-type multi-units. We took an impression on a multi-unit level. Now, this is a simple restoration. We don't need to do anything too complicated to restore this area. You just take impressions and make a temporary restoration from PMMA to see the morphology and to check how it fits to be sure that everything is fine before you make the zirconia bridge. Now, we took off the old PMMA bridge from the upper jaw that you can see here, and the yellow part is the candies that she probably likes to eat. This is probably the main reason why she lost her teeth in the first place. You can see the first PMMA bridge is on 2 implants and the new PMMA bridge is on 3 implants because we've added an implant in place of the canine. And this is the time where we want to mount the implant and have the full bridge on 3 implants. All the multi-units that we took impressions of were straight V-type multi-units, but we saw that the screw channel is not in the most comfortable place, so we wanted to shift the screw channel a little bit in the palatal direction. Hence, we changed the V-type multi-unit to an angulated D-type multi-unit, as you can see here. So right now we have here 2 V-type multi-units and 1 angulated one. The angulated multi-unit is used to shift the screw channel to the palatal area of the bridge so that we won't see the screw channel buccally on the canine. You can see here after we switch the screw channel to the palatal area, the screw channel is now in the aesthetic position. So you don't see the screw channel at all. However, you do see the screw channel For the second implant, the middle one, it comes to the buccal part. But in this case, when we have a zirconia bridge, we can cover it with a little bit of composite and you won't see it at all. It won't be such a big interference in the aesthetical aspect. You can see here all the steps. So at first, we had the temporary bridge. You can see that we have a healing cap on the angulated multi-unit and 2 straight multi-units. We took the healing caps out so you can see the cone of the angulated multi-unit and 2 of the straight ones. Now you can see the bridge that covers the cones of the angulated and the straight multi-units. Same way, we also mounted the 3-unit multi-bridge on the lower jaw. Those are the PMMA bridges, and we want to make sure that they're fine in the morphological aspect to check the functionality and that she's comfortable with the bridges. We never make zirconia bridges from the start. You do want to see if the morphology of the shape of the bridge is the right one. You want the patient to feel out the bridge a little bit to see if they're comfortable with it in the first place. With angulated multi-units, we have a little bit of a problem. We have a buccal bulge and it's problematic in the aesthetical aspect. After all, in the buccal bulge area of the crown, you have the highest part of the multi-unit because almost always you would prefer to shift the screw channel to the palatal surface. When you use an angulated multi-unit, make sure that the buccal part will be at the same height as the gingival line. The palatal part of the multi-unit will be a little bit below the gingiva. So in this case, you can see that the buccal part of the multi-unit is the same height as the gingiva, but the palatal part of the multi-unit is a little bit below the gingiva. We close the screw channel temporarily so that later we can open them back up. This is a temporary restoration. We are planning to change it to a permanent zirconia restoration later on. You see that we've added a little bit of pink glaze in the gingival area, so you won't see it when she smiles because she has a little bit of a high smile line, but in the psychological aspect, it's a little bit more comfortable when the height of the teeth are at the same line. She won't have a huge canine. In the occlusion part, we want to have it with a little less glaze as possible because the zirconia itself, when it's polished, almost doesn't wear the teeth at all. So we are adding glaze in the buccal part and the palatal part, but the occlusion part is polished. Now, the lower bridge was treated in the same way. When the restoration itself is polished, you have less plaque accumulation and you have less inflammation. Now, the integrity of the restoration is much better. So therefore, even the gingival part of the bridge that we don't see here, we don't want to be polished zirconia. You can see that the frontal crowns that are on the teeth have a little bit of an aesthetical issue. Their time will come, and in the meantime, she had a new zirconia bridge on her lower side, upper, and right lower. You don't see any inflammation because the upper part of the gingiva, the attached gingiva, is white. It's not red and swollen. From a hygienical point of view, she doesn't need to have bad hygienical situation. Here you can see both bridges after the glaze and the polish before we cemented the sleeve. And this is the final picture. You can see that she does have a little bit of chipping in the frontal bridge, maybe because all of the yellow candies, but all in all, you don't see the glaze of the gingiva and you don't see any screw channel. Everything is screw retained with optimal aesthetic results. Thank you everyone that joined in to learn some new and interesting information. Make sure to stay tuned for more. And of course, don't forget to subscribe, like, and follow. Thank you guys and see you next time.